Hello everyone. This year at Health Up, we took a very exciting step forward. We conducted the hackathon for students for the very first time. The idea behind this competition was simple yet powerful: to give young innovators a platform to apply their technical knowledge and problem solving skills to some of the most pressing challenges in healthcare. Healthcare today is changing rapidly, and real world evidence, data science, and predictive analytics are at the heart of this transformation. Chronic diseases like diabetes, COPD, and heart failure contribute to the majority of healthcare costs and frequent hospital readmissions. We wanted to see how can students, with a fresh perspective and energy, build solutions that are not only technically strong but also practical and impactful for real-world use. Over the past weeks, we received an overwhelming response for more than 40 teams registering from university across the country. These teams work tirelessly on their ideas, developing AI, machine learning, data analysis, and also innovative healthcare applications. They tackle the problem statement, like predicting hospital administrations, tracking disease progression, and generating actionable insights on providers. From these 40 teams, we had multiple rounds of evaluation where submissions were reviewed for originality, feasibility, technical depth, and real world evidence. After careful consideration, we narrowed it down to help top two teams who will be presenting their solutions today. A big congratulations to them. We have both of the teams today to present their submissions with us. With this, I would like to invite our first team from Maharaja Sairaj University, Baroda. Um, we have representing Maharaja Sayaji Rao University, Baroda, Brijesh Shankat. He is pursuing his MSc in Applied Mathematics from the Faculty of Technology and Engineering. Brijesh is passionate about data science and analytics and is constantly working to grow in this field. Outside academics, he balances sports, leadership, and academics with great discipline. In fact, he is also the head placement coordinator of his department. Over to you for your presentation, Brijesh.
Good evening, everyone. Myself, Brijesh from Applied Mathematics, MSU, Baroda. So, let me just quickly start with the presentation. So, our project title is Readmission Prediction and Cost Estimation, presented by my teammates, Brijesh, myself, Harsh Sutaria, Amir Hamza, Yogi Panchal, and Sahil Meenia. Now, coming to the problem statement and motivation. Hospital patient readmission, particularly within 30, 60, and 90 days of discharge, present a significant challenge to healthcare system. These readmissions not only drive up cost but also indicate potential gaps in care delivery, placing immense strain on resources and staff. Now, motivation. Understanding and accurately predicting readmission risk is crucial. It enables targeted intervention strategies, significantly improves patient outcomes, and elevates the substantial financial burden on both patients and healthcare providers. This is a key metric for evaluating providers' performance and quality of care. Now, coming to object of our project, so mainly chronic diseases impact and costing escalating costs. So, chronic diseases and comorbidities means more than two diseases, are major drivers of high readmission rates, posing complex care management challenges. Each readmission significantly increases healthcare expenditures alongside substantial emotional and financial stress for patients and their families. Now, it's a real world problem. Like hospital readmissions are a major global healthcare challenge, leading to avoidable patient suffering and billions in extra costs each year. By predicting which patients are at highest risk of admission and estimating the associated financial burden, healthcare system can proactively intervene, means make it better through target follow-ups, home care, and optimized discharge planning. This not only improves patient outcomes and quality of care, but also reduces operational strain on hospitals and financial losses of insurers in patients such predictive models support value-based care, efficient resources allocation, and long-term healthcare sustainability. Hmm. Now, the dataset overview. So we used three datasets, majorly beneficiary summary, which was 2008, 2009, and 2010, and inpatient claims and outpatient claims for for the decade, means for the period 2008 to 2010. Now, some of the highlights and important features of this data. In beneficiary summary, we had demographics such as age, gender, race, and existing chronic conditions. In inpatient claims, we have detailed records of hospital admissions, diagnosis, and associated costs. Outpatients, we had information on doctor visits, lab tests, prescription, and their respective costs. Now, for this, we have started with the pre-processing. So before pre-processing, we merged all the data set with the keys of person ID key. Then we started the simple pre-processing by cleaning, then missing value treatments and feature extraction, going through the EDA process, then normalization and outlier correction also. Further, these are the analysis and feature engineering. In demographics, we have the graphs for readmission rate uh, by age groups. Means we have divided the age group from 20 to 29, means 30 to 39, and going in the same way up to 90 to 99. Then these are the readmission rates, and also we have uh, readmission rates in the on the basis of race codes. On the means white, black, white, and Asian on the three the race codes. And also we have chronic conditions, means on the basis of diseases, how the readmission takes places in 30, 60, and 90. Now, going to the key engineering features, age and chronic burden. Higher readmission risk is strongly correlated with older age and an increasing burden of chronic diseases and notable disparities. Evident differences in readmission rates and cost based on geographic location, race, and gender, indicating areas for target intervention. Now, our model development. So we used two models. One is XGBoost, extreme gradient boosting, and random forest. So we used XGBoost for because it was a highly efficient and flexible implementation of gradient boosting, known for its predictive power and speed. And we used the rainforest for because it was an assemble learning method that builds multiple decision trees and merges their predictions to produce a more accurate and stable forecast. Now, training and validating approach. So, first we trained all different models with 30 days, 30, 60, and 90. We had prepared different models with different key features, and then we have used the group shuffle split with 80 train 80% train and 20% split to ensure patient independence across sets. These are the accuracy we have received in our model: accuracy of 85.55%, precision of 65.69%, recall of 48.89%, and F1 score of 56.67%, and similarly ROC accuracy of 81.01%. Now, outcome prediction. So, in readmission prediction, we have binary prediction of readmission risk for patient within the 30, 60, and 90 days of post discharge, and for the cost of readmission estimation, predicting the financial cost of readmission at both individual patient level and aggregated cohort level, with a special focus on cancer patient. Now, outputs. In individual risk, personalized readmission risk scores accessible via predict readmission by ID. Means we can enter ID and we can get the data of the particular person or disease, or through the disease also. High risk patient count. Aggregate number of patients identified as high risk, enabling target resources allocation. And in estimated cost per readmission, qualifications of the average financial burden per predicted readmission, aiding and financial planning. Then these are some insights and visualization. So the first visualization is a readmission of 30 days per population, means per how many patients were there and how much is the readmission rate. Within 0 represent no readmission and 1 represent readmission within 30 days, 60 days, and 90 days. And the down here we can see the drug, the medicines which were used frequently, and on the basis of patients, how many patients were given this much drug, and on different. And these are the vocabulary IDs. Now, actionable recommendation, what we can implement. And early inventions, implement early inventions for high risk or elderly patients and whose those with specific chronic diseases. Policy level recommendation, advocate for the adoption of predictive analytics in healthcare policy for hospital performance improvement. Benefits to patients and healthcare providers, so enhance post discharge care, strengthens post discharge care programs and patient monitoring protocols to reduce relapse. Then tailored resource allocation, utilize model prediction to personalize outreach and optimize resource allocation, and address disparities, symmetrically review and target geographic, racial, and gender-based disparities in care. Now, this is a live demo. We have a web application link also, and this is a screenshot of the web app, and this is the feature. So I'll just quickly screen share and show you the web page. This is our web application. So first, see, this is overview, total patients, then 30-day readmission percentage, then average cost per patient, model accuracy, and risk distribution. And this is the time window for risk, 30 days, 60 days, and 90 days. Also, we can this is our ML model. We got the highest accuracy in XGBoost, accuracy 87.3%, then random forest in 84.1, and other. Hmm. So this is our prediction model, a prediction feature in which we can enter here. I have already selected a patient ID, and by chronic condition, like if I know if for a person, that person has a cancer, then then we can risk predict risk, and yeah, these are the risk predictors for. And similarly, if we go for more than one diseases, then the risk and the increases. Similarly, with the cost analysis, we have the cost analysis of diseases on the base of diseases, like for each and every disease we have a different cost, and which was already featured in the model. So it shows the cost as per the diseases. And these are some key insights, that high impact conditions like CHF and CKD are the strongest predictors of readmission risk. Then cost optimization, 25% of cost reduction possible through target inventions. And similarly, the risk distribution, 9% of patients are high risk, requiring intensive management from the data sets we were given. So these are the demo, and this is just a preview tab. We have not fully functionally completed this web application. We have not attained 100% accuracy, and recall rates are also not that much accurate. Okay, so now moving further, now future scope, how the solution can be scaled to other data sets or healthcare system. Model refinement, conduct deeper hypermeter tuning and explore advanced ensemble techniques to further boost model performance. Data integration, scale up the incorporate additional real-time clinical data streams such as electronic health records, EHRs, and wearable data set, wearable device data. Means we can use the current data sets, which can be used by hospitals and can be utilized for predictions and cost estimation using this web app. Now, see, pilot programs, seek collaboration with hospital and insurance providers for pilot programs to validate model in real world settings. Then cost modeling expansion, refine and expand cost modeling integration, further financial and clinical features for more granular estimations. And generalizability validation, validate the model generalizability on a diverse patient population and data set to ensure broader applicability. Then potential collaboration with hospital. We can collaborate with hospitals and insurance companies, and for the same, and we can uh, predict the hospital readmission risk and estimation costs, requiring strong collaboration across healthcare stakeholders. Conclusion. So our problem statement was hospital patient readmission, particularly within 30, 60, and 90 days of discharge, present a significant challenge to the healthcare system. This readmission can not only drive up cost but also indicate gaps in delivery. So we for this problem we used machine learning models as XGBoost and Random Forest, and we have developed a model for predicting a readmission and cost estimation. Why our project matters for the future. In this project offers a clear path to shift healthcare from a reactive to preventive paradigm. By doing so, we can significantly improve patient outcomes, enhance operational efficiency for hospitals, and optimize resources utilization for payers. This represents a tangible and transformative steps towards a more effective and equitable value-based care system. So this was our presentation. Thank you everyone for joining us. Any questions regarding the same?
Thank you so much, Brijesh. The presentation was amazing, and I think it was really innovative. And in fact, it was a really good work from the team. I believe this could be a really good inspiration for other students as well. So, thank you so much.
Thank you.
Next, I would like to introduce our second team from Nirma University. Our second finalist team, Harsh and Hetwi, represent Institute of Technology, Nirma. These are two dynamic students who are passionate about data, problem solving, and exploring innovative technologies. A little bit beyond them, about academics, Hetwi loves reading novels, traveling, and dancing with a deep passion for data analysis and exploring innovative ideas. Harsh brings a very diverse set of interests, from finance, stock markets, and economics to AI/ML, computer vision, NLP, and data analysis. He also enjoys chess, music, and learning beyond academics. I welcome both of them to present their solution to us today. Over to you, Harsh and Hetwi.
Good evening, everyone. Myself, Hetvi Vanzara, and I am from Nirma University. Our team's name is Predictors, and we developed the solution consisting of 5 members: myself, Hetvi Vansara, Krish Marakana, Harsh Khanna, Himanshu Mishra, and Urva Gandhi. So, the problem statement and motivation. Today, healthcare systems face 3 main challenges. First challenge is chronic diseases like diabetes, heart failure, and COPD are rising globally. Second is patients get discharged, but they come back to the hospital within weeks. And repeated readmissions increase burdens on both hospitals and patients. So, our motivation was to identify these high risk patients early so that hospitals can provide timely care. So this will reduce the drug disease progression, estimate treatment cost and potential savings, and support providers with actionable clinical insights. So we can move from reactive treatment to proactive prevention. So, our clear goal and relevance. So, clear goal was to predict hospital readmissions in 30, 60, and 90 days, track disease progression in chronic patients, and estimate the treatment cost and potential savings of such chronic patients. And real world relevance was that doctors can get early warning signals about these chronic patients, hospitals can reduce avoidable admissions, patients benefit with better outcomes and less expenses, and it ensures the governments to save on unnecessary claims. So essentially, our project makes healthcare smarter, faster, and cheaper. So the dataset overview. So the data set overview, we used CMS data, beneficiary, inpatient, outpatient claims, and prescription events. So important fields or features for the particular data set was age, gender, race, then chronic conditions, admission and discharge dates, and cost and reimbursements. So the pre-processing that was required was to clean the missing and inconsistent data, convert the categories to numbers, and we also created new features such as readmission labels, cost totals, and hospitalizations. So these new features can help the model to predict the data correctly. Okay, so data analysis and feature engineering, demographics, age, gender, and race. We studied the patient's demographics that help us understand different risk groups. Then chronic condition distribution, diabetes, CHF, COPD, cancer. These are the chronic conditions which usually patients have, and how they are distributed across various patients. Then hospital visits, prescriptions, and cost patients, readmission counts, length of stay, prescription patterns, and cost trends. We also studied these descriptions and cost patterns about the patients, and the new features that were engineered were days since last visit, number of hospitalizations in 30, 60, and 90 days, medication adherence score, and total cost per patient. Okay, so model development, we used four algorithms. First was logistic regression, random forest, XGBoost, and deep learning. So logistic regression was very simple and it was used as a baseline, but actually it did not fit the data correctly. So we moved to random forest and XGBoost. These are powerful algorithms and they were used to perform on complex features that the dataset consisted of. So it provided better performance. And deep learning was used to find the hidden patterns that were consistent in the data. uh, and the training, how we divided the data set. So we trained our data, or we trained our model on 2008 and 2009 data set, and we tested it on 2010. So this kind of split helps to reduce the overfitting problem. So what is overfitting? Overfitting is such that when we use the same set of data, then the model will not be able to predict the new data that will be provided to it. It will fit the trained data very properly, so it will not be able to predict new data. So to reduce the overfitting, we split the data in such a way that the model will be trained on different sets of data multiple times. And the performance metrics were accuracy, precision, recall, F1 score, and ROC area under curve. We achieved a recall of 86% under random forest for 90 days. Outcome prediction. So our model helped predicting readmission risk for 30, 60, and 90 days, and it identified patients that had high hospitalization risk, and it also forecasted the disease progression trends for the chronic patients, how the disease will progress in the chronic patients. So what the actual output generated was a list of high-risk patients. So the hospital will get early alerts for these high-risk patients. Then medication adherence score, which means that which patients are not taking their medications properly. Then it also predicted the healthcare cost for each patient, and it also provided a personalized intervention recommendation for each patient. So now over to you, Harsh.
All right. So, good evening, panelists. Basically, uh, now we will be showcasing you the screenshots of the dashboard, and at last we will also be going towards the dashboard for best explanation. So, basically, so this is the landing page of the our data overview. Basically, we have basically 1,16,352 unique patient IDs, in which inpatient admissions and outpatient claims were also given. This is the overall insights and visualization of the data, which on the accuracy score, decision recall, and everything of all the four models in machine learning which we have used are given on the next slide. This is the graph which shows, see, random AUC 0.5%, 0.5 is the baseline matrix, which means basically flipping a coin. We are just randomly guessing the thing. Logistic regression, which is very simple, we got around 76% accuracy on 30 days and 80% accuracy on 90 days. But we got our best accuracy and recall on XGBoost and Random Forest. In XGBoost, we got 80.8%. The more the top left corner of the graph our curve goes, it means the more accurate our model is. So we got 80.8%, and in 90 days readmission rate, we got 84.4% accuracy, which is, I mean, we achieved this after so many number of different methods. So this is we built this dashboard visualization so doctors and decision makers can easily use our results for the conclusions. So, okay, this is the random forest feature importance. We will also show this on our website. This important feature importance means there are so many multiple columns in the data set, but we will choose the most important 15 columns on which we will be training our data set. We cannot use each and every, otherwise accuracy will be decreasing. So we tried and tested different kinds of permutations and combinations, and then we got the best under this 15 features. This is the another graph on right side is of the patients, number of patients versus the disease, like cancer or COPD. This many number of patients are chronically diseased with the cancer or Alzheimer or depression, etc. So in this actionable recommendations, uh, from our insights, we propose basically three level recommendation. First is early interventions, in which automated reminders, coordinated care, or medication reminders, regular follow-up alerts is because many patients they forget to go to the doctor regularly, and due to which many problems occurs in later stages. On policy level recommendations, reduce avoidable readmissions, better allocation of hospital resources, improve system efficiency, and these are some of the methods by which our policies can be changed for betterment of patients and betterment of hospitals. The benefits to patients and health providers are they are clearly visible. Better health outcomes, lower treatment costs for patients, improved hospital efficiency, beds will be empty, readmission rates will be lower, other patients can be benefited easily.